let me first introduce Marci, Dr. Marci. Marci is the executive director, or the chief executive officer, I should say, of Patient-Centered Primary Care Collaborative. And she joined PCPCC in 2012. And prior to that, she served as Vice Chancellor for Public Affairs and Associate Professor at the University of Kansas School of Medicine's Department of Health Policy and Management. Marci was appointed by then-Governor Kathleen Sebelius as first board chair and subsequently became executive director of the Kansas Health Policy Authority, the single state agency managing Medicaid and the state CHIP program, the state employee health plan, health information technology, and health policy. Holy moly. She worked as legislative assistant to Senator Bob Kerrey of Nebraska, and later served as the health lobbyist and assistant director of legislation for the AFL-CIO. Getting a theme here of policy and advocacy and activism, right? She's currently on the board of directors of the American Board of Family Medicine and the Center for Health Policy Development, the National Academy of State Health Policy, and is a former board member of the Healthcare Foundation of Greater Kansas City, Transform Med, and the Mid-American Coalition of Healthcare. She was a committee member for the Institute of Medicine's Leading Health Indicators for Healthy People 2020 and Living Well with Chronic Illness, a call for public health action. Early in her career, she served as a Peace Corps volunteer working in Thailand and served for 6 years in the U.S. Army Reserve. Dr. Nielsen holds an MPH from GW and a PhD from Johns Hopkins School of Public Health. And wow, right? And she's only 25. And most importantly, she is a very charming, articulate, and funny lady. So you're in for a treat. Come on up, Marci.
Good afternoon, and thank you so much for having me today. I have to tell you, I was kind of having a bad week. Just kind of nutty season, lots of annual meetings, and I've been doing a lot more traveling than I normally do. And I, of course, being a friend of Natalie and Larry Green and Ben Miller and so many of you here, looked at my schedule today and was so relieved that I get to come and talk to you all. But then I just got to attend your debate session. And I must tell you, my stomach hurts. I was belly laughing. And I leaned over to Natalie and I said, there might be something wrong with my life, because I think this is the funniest thing I've seen in like 3 years. And there is something wrong with my life, but there's also plenty right with my life. And so with that, I'm going to tell you about what's right with not just my life, because my job, as Natalie pointed out, is the CEO of the Patient-Centered Primary Care Collaborative, and there's so much opportunity for all of us, for public health, for primary care, but for health system transformation. It's a wonderful time to be doing what we're doing, and I'm going to tell you a little bit about that. But I also particularly love being here with all of you to talk specifically about the opportunities for behavioral health, which is very near and dear to my heart. So, how are we doing on slides? I told him, they were nervous miking me up, and I don't have a belt. I said, well, just use my sweater. And he was doing a double check. Are you okay? I'm like, I am so okay. If something's not okay, I'm just going to say, hey, can we fix that? And so there we are. So transforming primary care practices in pursuit of the triple aim, and a little bit about how great leadership can make or break the deal. I come back to the overall framework from which we're working, which isn't just behavioral health, and it's not just primary care, and it's not even public health. It is literally health system transformation we're talking about. And really the roadmap to get us there is the triple aim. You all know this, I well know this, but I'll tell you the American public does not know this. The American public, when you say, do you know what a patient-centered medical home is? They grimace a little and they say, am I going to a nursing home? Is it an institution? So when we talk to the American public, collectively, about health system transformation, they don't think triple aim, better patient experience, better population health outcomes, lower costs. They think comedy, drama, or tragedy. And so it is our job in all that we do, whatever hat we wear, to think about how we're translating what we do to the public. And that's not just because I love health policy and ultimately everything that we do needs to be embodied, embraced in health policy and paid for, but because unless we bring them in as real stakeholders, unless they really feel like this is about them, we will lose. As we so often in the world of public policy do. We make this about us and politicians, and we forget that this is about people. And we were just talking when we, with my table before dinner started, lunch, and I was pointing out I kind of eat food out of cans, and that's for lots of reasons, some of which aren't pretty. One of them is I was in the Army, and I think meals ready to eat are so practical, and so there's that. But my dad made Spam for a living. He spent the first 20 years of his career working in a meatpacking plant in Fremont, Nebraska on a line. And my mom was a secretary, and she did that working for the same State Farm Insurance Agency for 35 years. So I come from a small town in Nebraska. Everything I do and I care about is framed through that lens. And so although you'll hear lots of talk from the provider perspective and a little bit from the elected official perspective, for me, at the end of the day, it comes down to people who are voters, and this is about them, and a health system that we pay entirely too much money for and don't deliver good enough services, in my opinion. So, we're talking transformation. The Affordable Care Act provided us with a terrific platform to expand health insurance. It did that in many different ways, in the private sector, in the public sector. It is not perfect. It also provided us with some tremendous opportunities around delivery reform. But in many ways, our work is just beginning. We've got payment reform. We've got benefit redesign that needs to be a piece of this. And again, we've got consumers that have no idea what the hell this is, what their role is in all of this, and why any of this is good for us, meaning good for them, their families, good for the country as a whole and our economy. And what we need to do is get some real folks engaged in what we're doing. We all need to volunteer to be a part of that education process. Now, I'm always a little intimidated when I'm asked to be the keynote speaker, because really, had you heard of me before you got here? And you don't have to answer that. When I think of like a great keynote speaker, I'm like, oh, I bet they wanted Atul Gawande. That's who I'd want if I were you. So I'm just here to tell you, he's pretty fabulous. And he's fabulous for lots and lots of reasons. And I've just provided you with a couple of facts about Atul Gawande. What we mostly, in my world of health policy, know about Atul Gawande is he is able to convert really complicated and challenging and controversial ideas into stories that resonate with people. And it is being a storyteller that is what breaks through. The data, the evidence, necessary, not sufficient. So Atul tells us stories about what's wrong with our health system in a way that make us think, well, that doesn't make any sense. And what I would tell you is, I've got my own stories. And there I am with Atul. I did not wear my glasses, but they're at the table. And we've got a lot in common, me and Atul. I've highlighted them for you in red, in case you were wondering. Now, one thing that I do have on Atul is, he wrote a speech that he delivered at Harvard around the way in which we train health professionals that really was quite profound. And his speech was called Cowboys and Pit Crews. But I live in Kansas, and that's a state with real live cowboys and NASCAR. And so what I want to say about leadership and how this relates back to our work is that Atul is telling us, and he can say this because he's a surgeon, that in this country, we train, hire, and pay doctors to be cowboys. We pay them to be independent and tough and to stand apart and above the work that they are doing. And the debate that we had, which I just thought rocked, around whether we have physician-led PCMHs or we let other members of the team help lead PCMHs. How y'all could be so funny and teach an audience so much? Bravo. But we have historically come from a place where, as Dr. McDaniel so nicely pointed out, we train our docs to be cowboys. Why would we expect our health system to be any different than it is? We also pay for a system that incentivizes cowboy-like behavior. But Atul tells us that we really need to be thinking differently, and that, in fact, we ought to be training our health professionals to operate as pit crews. And he argues that changing this is the greatest task of your and my generation of clinician and scientists. And it literally goes beyond how we put students together in a room, how we think about team training and all of the competencies required. By the way, the PCPCC has a new publication that's coming out in November on this, and we've been working together with a whole host of folks from various disciplines. But it also changes to succeed. Move from cowboys to pit crews also requires changes in our values. Literally, we've got to become more humble. We have got to recognize, as Susan pointed out earlier today, we've got to recognize various folks can be leaders at various times based on the needs of that patient and their family at the time. But that discipline is required. This can't be chaotic. And I thought Dr. Simmons' points were right on the money. It's important that we have the patient's priorities first, but we can't be operating from a place of chaos. And that requires teamwork, which just doesn't happen because we'd like it to. And we put a bunch of folks in the room who happen to be trained differently. And so you see the Kansas Speedway there. I'm sure Atul lives in what? Connecticut. You got NASCAR in Connecticut, Rob? I'm thinking not. Interest in data, checklists, teamwork, these are all things that lots of clinicians, physicians in particular, go, right, a checklist? Yeah, that sounds like cookbook medicine to me. And I think that that's a fair assessment if that's all that we were arguing for. And for any of you who are currently going through NCQA accreditation or about to go through NCQA accreditation, as Ben Miller pointed out, this is not that. This is not, health system transformation is not just checking the boxes. It is much more than that. But that checkbox, as Paul Grundy points out, is a roadmap to help get you there, is a yardstick to see where you fall along the spectrum. If we stop there, our job is not done. So, we talked this morning, we listened, we chuckled in the debate about the evidence and whether the evidence, what was the quote? Dr. Blunt said something like, we could find evidence that if we asked janitors to smile, there would be evidence that suggests that there are health system improvements. Probably. But it is important, again, necessary but not sufficient, that we bring the evidence together around this model of care, around primary care, to suggest, hey, here's what's working, but guess what? Here's what's not working. There are gaps. There are things we do not know. And so What are we talking about? First, you need to define the terms. So I've got a lot of slides, and I'm going to hop through many of them quickly, and I know for some of you who are Zen and into the whole mindfulness thing, by the way, I am so crazy about Dr. Cabot Zen. I just read Full Catastrophic Living. Oh my God, do I need a lot of that. So I'm going to stress you out a little bit. So I want everybody to take a deep cleansing breath. Are we all? See, I can say this to you all, and you're like, I'm with it. I say this to a room of family physicians. They're like, really? Who hired her? Why is she here? Deep cleansing breath. We're going to get through some slides quickly. Defining the medical home. You see, we're using the ARC definition of PCMH. Now, I'm going to get to the very interesting conversation about superutilizers versus everybody else, and I'm here to tell you that the debate this morning was very useful and the vote was very instructive, because the reality is we got to have both, and I'll show you some data to suggest why. Yay! I would also submit to you that there are a lot of folks who think, oh, Marci's here, I guess we're going to talk about primary care for an hour. And I'll tell you, if that's what we do, if that's all that we think about, we have also missed the boat. Because the reality is we can fix primary care and make it perfect, and it's still 5% of our total healthcare spend, just 5. So if what we want to do is accomplish health system transformation, our challenge is to work across the medical neighborhood, although I hate the term medical, across the real neighborhood, and start with the world of accountable health care as recently defined through the Affordable Care Act, recognizing that PCMH is the heart of what I'm here to talk about, and primary care and its role in care coordination. But we've got to be partners, real partners, with everyone else in the healthcare system, and I've outlined those for you on your right. You'll certainly see mental health listed there, but I'm going to come back to this. On the left, however, is where people really live and work. It's where people are healthy or not. They are in a clinician's office a teeny tiny portion of their waking hours. And in reality, if what we want is health system transformation and a healthier population, we've got to be thinking as much about the left side of this slide. It is your left, right? Correct. Public health, schools, employers, faith-based organizations, community centers. We have to spend as much time thinking about the community and where people live and work and play as we do healthcare. And yet, the United States is one of the few industrialized countries in the world that literally health and healthcare, we think they're the same term. At some point, we came to believe that our healthcare was somehow determinant of our health, when we're just 10%. And so please know that I get that. I'm going to talk a lot about health care, but health care has to link back to patients and families and communities. So we can also talk a little bit about the political reality of making this happen when money is tight everywhere. And although this looks like a slide that the Commonwealth Fund has produced and looks at industrialized countries relative to the United States around healthcare expenditures, this is actually a slide about politics. And it's a slide about bipartisanship, and the bipartisanship that does not exist in this Capitol. Wow, talk about need for a deep cleansing breath. It doesn't exist here, but unfortunately, it doesn't exist in a lot of state capitals either. And I must tell you, I worked for 10 years in federal health policy. And I, kind of drunk the Kool-Aid. I really thought, wouldn't it just be better if Medicaid was just one program and we had the same thing for everybody? And then I went and worked for the state. And I assure you, I quickly changed hats and realized, wow, does the federal government not get it? And if any of you have work for the state now, you understand why one size doesn't fit all. Kansas is very different from California. And now I need a deep cleansing breath. You get where I may have a personality less predisposed for Kansas than California. This slide points to the fact that if half of all the dollars in this country are linked back to the private sector, and half are linked to government. Government alone cannot come up with solutions to fix our broken health system, but neither can the marketplace. And we've got so many folks running around this city who think, let the market fix it all. Not possible. Not possible when Medicare and Medicaid and now the state insurance subsidies, not possible if, in fact, we look at the data. But we've got lots of folks that run around this city, too, thinking, you know what, we'll fix Medicare, we'll fix Medicaid, screw the private sector. Not realistic either. Our opportunity together is to convince them that this only works when they're in it together, and we look for alignment between big government and industry solutions, and everybody takes their preconceived notions about the other team and throws them out the window. The beauty of my organization is that they figured this out a long time ago, long before I came to the PCPCC. There are, in fact, lots of folks who care deeply about these issues, who operate in both silos, and certainly in the not-for-profit world. So, please know that this talk today is nonpartisan, and we've got to be nonpartisan and certainly bipartisan if we want to make progress. Now, the first thing a policymaker is going to tell you is, oh, super great, your program, love it. Where are you going to fund it? There's no new money. There's no new money at the federal level. There's no new money at the state. And they are correct about that. We've got to change the way we fund health care. And you know this as well as I do. Every study that's looked at how we spend money in our fragmented, siloed healthcare system says that somewhere between 30% and 40% of what we spend is overuse, underuse, or misuse. That's where the new dollars have to come to fund what we're talking about. But you can't flip a switch. That transition is slow, and it's often painful. And in this town, it's also very frightening for the haves when it looks like the have-nots are about to get a cash infusion. So for everybody who's making bank in today's healthcare system, and you're out there, probably not here, you're out there, you're going to defend the status quo. And that is what we are up against. Our enemy is our friend, but we've got to convince them that there's room for them at the table. And the way to convince them is both through data, as well as through stories, as well as through changing our values. And the value that I would put at the very top is patient-centeredness. If you focus on that patient and what that patient and their family needs, the solutions quickly, at least some quickly, come to mind. So, employers, they have historically focused on how much money they spend on health care and insurance premiums in particular. But they also look at their pharma cost. They look at their worker comp costs, and I ran the work comp program in the state of Kansas. It's real money. But if you dig beyond that, even at a surface level, employers quickly start thinking about productivity. And that's both absenteeism as well as presenteeism. And think about what happens to those people's lives when they are robbed from either being able to work or robbed from being really present at work because they feel awful. And what does the health system do for them to help get them back on their feet? And no offense to my friends Jeff and Ben this morning, because you all had a perfect solution in terms of let's all come together. They have debates about, do we make this super utilizers or do we make this PCMH? You see how quickly we're all bickering over a pot that is only so big. And the reality is we need to expand that pot and we need to spend our money smarter, because this impacts real people's lives, and not just if you look at how much money we spend on health care, but the quality of their life. The quality of their life. So, you know this better than I, but apparently, although we've been sharing this data for years, employers have only recently woken up to this. The top 5 conditions that employers spend money on have a behavioral health connection. And yet we fund everything differently. We underfund one system and overfund the other, some would argue. We are now moving toward integration in a terrific new way. And I'll share with you some data. How many of you saw the Health Affairs article that came out just this week on ACOs and how many of them are integrating behavioral health? So a good news, bad news story. There's actually a study on behavioral health integration in accountable care organizations. Who knew? How many of you know what the numbers look like? True integration. Okay, I want you to raise your hand. True integration in ACOs of behavioral health into primary care. Raise your hand if you think the number was between 0 and 20%. Okay, 20 and 40. Okay, 40 and 60. Oh, yeah, never mind. Experiment done. It was 14%. 14. So that's the bad news, although maybe the good news. Then we had some inklings of behavioral health integration into primary care, okay? So you get 3 buckets. Perfect integration, no such thing. Some integration, 0 integration. These 2 buckets, 43%. So we've got 43% of ACOs not integrating behavioral health at all. But 43% have started. So that's our opportunity. What can we do to help those ACOs have success around behavioral health integration? And what can we do to tell the story in the 14% who are integrating? What can we learn from them? And where isn't it perfect? Where can we keep improving? And then we need to come back with the data around behavioral health conditions and share that data and demonstrate that this is worth the return on investment that employers will require, not ask for, and actually not even be polite about, require. ROI has to be part of everything we think about if we're sincere about health policy. So, we heard Star Wars this morning, and Barbara Starfield was mentioned. How many of you knew Barbara Starfield? So you all know that she was the goddess of research in primary care and a professor of mine at Johns Hopkins, and we do have over 200 studies of Barbara's and many, many others in the field that point to the effectiveness of primary care. But we need more research and better research that tell us which pieces of primary care work best for which outcomes. And that's what I'm going to talk to you about a little bit today. I'll tell you the challenge is, even with 200 plus studies and all of Barbara Starfield's terrific work, primary care still remains incredibly undervalued. It's 4 to 5% of our overall healthcare spend. 4 to 5%. Did you guys know it was that low? Neither did I. And we're about to, I think, raise a little hell, because I think the world needs to know that 4 to 5% is all we spend, and hey, we're only asking for like 10%. So stay tuned for the next campaign that we need to be working on together, collaboratively, that says we underinvest in primary care to our own demise, and primary care must include behavioral health integration. Must, not an option, not a good idea. It is a part of primary care. I'm happy to tell you that we're trying to do useful work on your behalf and everyone else's behalf when it comes to, okay, but I need a cheat sheet. I'm going to go in and talk with an employer. I'm going to go in and talk with a public policy maker. I'm going to go in and talk with a health plan. Is this model working? Are we certain we're moving in the right direction? And the job of the PCPCC is, together with many others, and I see my friend Andy over there, our job is to share the evidence with you in a way that I hope is useful. We have a new terrific map that if you haven't already seen, please go and look at your state and see how we're demonstrating information about which programs are happening in your state, and then what we're learning about those programs. You can literally click on cost savings. You can ask for only industry reports or only peer-reviewed studies. And you can ask for specific states a number of search features, all in the effort of helping us tell our story and us being a resource to you. And if something's missing, please, please, please let us know. You know, I'm going to tell you the dirty little secret of the PCPCC. Are you ready? Like, how many of you had heard of the PCPCC when you got here? Okay, thank you. We love you. How big do you think the PCPCC is? Because it might appear that we look ginormous, right? Okay, so now we'll do another guessing game. Marci's staff is between 1 and 5 staff members, 6 to 10 staff members, or 6 and above. Yeah, it's 6. We got 6 people, and one of them is a free intern, so really it's 5. So when we say it's a collaborative, here's what we really mean by that. Yeah, we ask for a lot of free work from all of y'all. So please do go and help us populate this map and keep it accurate, because this is one of the many things that we are trying to do to help us tell the story. And there's a demonstration for how you can filter the outcomes. And this is the sort of thing that you'll see if you go, for example, and say, I want to see cost savings by industry report and peer-reviewed studies that were published in 2014. And you can look at the programs who have published on cost savings. We'll tell you what the cost savings are, and then you can click on each of the programs and see drill-down information about the program. Why is that useful? Well, when it comes to policymakers, really, what they want to talk about is cost savings. And Natalie makes this point, and we'll be making it again this afternoon in our concurrent session. If you come in to talk to policymakers and you don't bring money about what this costs, they're going to start looking at their watch pretty quickly. But if you go out to talk to patients and consumers to talk to them about why this model is fabulous, and this is all you bring, they're going to tune way out very quickly. When you talk to patients and you talk to families and you talk to healthcare providers, quite frankly, they want to know how this benefits our health. How do we improve the health system? But policymakers need data about money, and the good news is we're collecting it all. So please do visit us. Payment reforms, as I've just pointed out, we got to pay for this model of care, and we're getting there. A new study that came out just 2 weeks ago by Asaf Bitton and Bruce Landon at Harvard and others looked only at the PCMHs that are in fact doing some kind of payment reform. From 2009 to 2013, the number of PCMHs went up 4 times, quadrupled. The number of patients treated in those PCMHs quadrupled. Out of 21 million Americans, we've got about 70% of those who get their care through a PCMH, their provider is getting some kind of reimbursement for better care. And that's what we got to move to if we want this model of care to be sustainable. So what am I talking about? I'm talking about changes from a fee-for-service system to a value-based reimbursement system. It gets complicated fast, but the good news is we've been studying this for some time. And this is fundamental in this city and in your state capitals. If we want this model to be available for everyone, we've got to be sincere in paying for it. Easier said than done. Medicare, testing a lot of terrific models. The Center for Medicare and Medicaid Innovation, breathtaking in what they've taken on. But we need to all get in the game and help push them over the edge, because they can stop where they are. The CPCI program, for example, the Comprehensive Primary Care Initiative, 7 regions. If we want that model of care for everybody, we need to argue with our policymakers with data and with stories why everyone needs to shift away from volume-based reimbursement to value-based reimbursement. Now, how does that link to you and your work and the PCMH, but behavioral health? What if you work for a health system? What if you're at a hospital? Well, the link between PCMHs and the bigger, broader world is they're the foundation, they're the building blocks of a medical neighborhood that begins with primary care, looks across the street at the hospitals and the specialists with whom we absolutely must partner, thinks about how we pull in those care managers and care coordinators. I love that debate too. Oh, that was so funny. Why am I blanking on Jeff? Is he here? Oh my God, you're funny. I actually just thought of leaning over to Natalie and said, I'm going to give it to that guy. Although I like that Andy Pomerantz swore. I heard him say a swear word, which I love to swear. So I will just tell you, I already hearted him. Big hearts for Andy right now. Public and community health. I'm a public health person. I started my career in the Peace Corps, working for Thailand's Ministry of Public Health. I came back to the United States and started working for Senator Bob Kerrey. Do I have any Nebraskans in the room, by the way? All right, where are you from? Oh. Great. We don't. Yeah, thank you. We call it Omaha, but I'm just. But what I will tell you about working for Bob Kerrey, if you don't know him, former United States Senator, former Navy SEAL, former Congressional Medal of Honor winner, loves to swear, brilliant, funny, cares desperately about real people, is what I learned from Bob Kerrey was bravery. And what we've all got to do is we've got to be brave enough to partner with people who we've never partnered with before, and we think maybe are kind of a pain in the ass. Have you ever been around public health people when we get to talking about our budgets? Oh my God, we're so tedious. All we want to talk about is we've been screwed for all these years and no one ever funds us and all the money's in healthcare. Wah, 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 wah. You know what? We're about to change that. And unfortunately, it sometimes takes a public health disaster to wake public policy makers up. And how horrible for the people of Africa that it takes Ebola in the United States for Americans to even open up their eyes, but that is the reality. And now we're paying attention because all of a sudden we have doctors and nurses that are dying from an infectious disease because we quit paying attention to public health. So the public health folks have to be humble and have to have a new attitude because they have a new seat at the table, and we never had one before. And the same thing holds true for behavioral health. We have a seat at the table in ways we've never had before. And now that we're here, we need to both be brave to raise hell and be brave to hold our fire if there is a compromise that can be made that works on behalf of patients and families. So when you get all these folks working together, you've got a medical neighborhood that bounces in, that we need to rename. And when we've got all those folks working together and we've got measurement for real outcomes, now we can start paying for that model of care in brand new ways that align our interests instead of make us diametrically opposed. ACOs are growing. Benefits are being redesigned. I took out all my slides approximately 20 minutes ago on benefit redesign, given that you don't want to hear me talk about that for 30 minutes. The public engagement piece I've been talking about all throughout the course of my talk this afternoon. But if we are sincere about starting with the patient, public engagement is not only engaging the patient in their own health, you know, Prochaska stages of change. I might tell you, you would like to know this. Hopkins School of Public Health is so big, and the Department of Health Policy and Management was so big when I went there that they make you specialize at Hopkins. That's crazy talk, Marci. Hopkins makes you specialize. And my specialty was social and behavioral science. Did you know that? Okay, big group hug. Okay. So back to the triple aim. Andy's over there going, wow, I did not know she was this weird. I'm almost done, but I do have to tell you, we've got data, we've got evidence that speaks to how we lower per capita health costs. And it does mean hotspotting. First and foremost, hotspotting. It's true. We love hotspotting. You've got to be focused on your high-risk patients and give them what they need. That is where you will get your first initial savings. But if you stop there, you're just still part of a fragmented system. Jeff Brenner walks on water. But the reality is, Jeff would be the first person to tell you, don't stop at just the people who are really high cost. and really need intensive healthcare services, we need to be preventing people, as Ben says, from falling in the river in the first place. And it will be so tempting for us to gravitate to the high utilizers and say, oh, we're done now. Except, how goofy is that? So more people just become high utilizers because we never think about prevention. We never think about empowering a community to take on population health. So yes, we got to manage our high-risk, high-cost populations, but we've got to look at our medium-cost, manageable risk patients too, and we've got to look at the overall population that needs a little outreach, screening, and love, because this is all about relationships. It is relational, Ben Miller. And what's so funny about Ben right now is he's typing, because I know he's tweeting about me. Aren't you, Ben? Is that what you're doing? Uh-huh. I didn't see you hold up your camera and take my picture yet, but just 1 second. Okay. Okay. You guys were so theatrical this morning, I'm like, I'm gonna go crazy. We do know how to give a better patient experience of care, and a lot of that does begin with relationships, but it also begins with convenience. Why is it everybody else has figured out how to be convenient, but not healthcare? You gotta sit in your doctor's office for 2 hours with your time wasted. Wasted! Where are your group visits? Why aren't you thinking of how to spread the love between all of your diabetic patients, sorry, Ben, who in fact benefit far more and learn a lot more from their buddy or about to be buddy in peer support than they're ever going to learn from that doctor. Dr. McDaniels had that right this morning. And they've got a support network that they're now building at the same time. They're learning more, they're building social support. That takes communication, and Dr. McDaniel and Deborah Roeder was a professor of mine, so she taught me well. Improve population health outcomes, near and dear to my heart. It is one patient at a time, but we gotta be demonstrating how we're changing the health status of populations, and the way we've gotta do that is through information technology, and we need interoperable, better information technology that includes registries and EHRs. Oh my God, our high-tech company's making a lot of damn money for selling us 15 different gadgets. Why can't that all be in the same one? We just paid $5 zillion, right? So that is also something we can organize around. And the technology that we use in behavioral health, totally different technology than what we use in physical health. That needs to be integrated too. We got to think about patients and consumers and be bringing them in and having them help us test everything we're doing at every place along the way. We've got to do that using, I loved the argument this morning about case managers. Dr. Blunt obviously knows so very much about the importance of going out to real people where they are, and utilizing folks in the community, the promotores, and it's the Peace Corps model, right? How are we engaging people where they are? And it's with all these folks at the table, and it's with folks that we haven't invited to the party before. So with that, I'm going to flash super quickly through my behavioral health slides just because I want you to know that I have them, and to thank many of you that have developed these. These are hot off the presses. We've got 2 sets of behavioral health slides that are now publicly available on our website. They're the first slides that the PCPCC has ever made publicly available for download, because we think they're so incredibly important for people to start using. And so, everybody, are you ready? We're going to go really fast. Behavioral health, why it needs to be part of the PCMH. Go. Prevalence. It's the de facto mental health system. And the reason why I'm not reading this is because you all do know this, right? Okay. Unmet behavioral health needs, astounding in this country. We're often pointing our finger at a physical health need when the real problem is behavioral health. Of course, I made this point early in my talk about the leading determinants of health are, in fact, something other than health care, behavioral health at the top of that list. The comorbidity is unbelievable. When you share this data with public policy makers, it's often their first aha moment. We've got so many people who aren't getting access to services. a friend kill herself last week, a family friend, and talking to my dad last night, and he just kept saying, I just don't understand. I just don't understand. Why can't we find people to help them? Because in Fremont, Nebraska, we don't have enough behavioral health providers, Marci. And I said, we don't have enough behavioral health providers in lots of places, Dad. So too many people still hurting, and too much work for us to take on without integrating into primary care and doubling or tripling or quadrupling our impact. The high cost of unmet behavioral health needs is what will make policymakers wake up, and we've got lots of data that point to this. You know what's terrible about this? Is like, this is the one set of slides I should go through really slowly, because you're all referenced in this. Like Dr. Blunt has to be going, that's my slide. Did you see my name on that one? CJ Peak. I wrote that, Marci. God, you suck. Why are you going so fast? Super sorry about that. Improved mental health outcomes, improved physical health outcomes, improved patient satisfaction, improved provider satisfaction. We've got integration and evolving relationship. We are learning more and more about that. We've got some terrific resources that were just published in the last month. Have you guys seen the stuff that Qualis did, funded by the Commonwealth Fund, on the toolkit? We just had a call yesterday. By the way, it's recorded. I listened to it this morning in the cab. A terrific conversation about that toolkit and literally a roadmap for how to integrate behavioral health into primary care. This is some of the new data that just came out from Health Affairs this week, and this is around those places that integrate, the seven most common things that you see in terms of service providers screening, and then what you see least commonly, meaning we got a lot of room to grow. This conversation. Andy was cracking me up this morning with his psychiatry. Yeah, they got psychiatry in lots of places, but no health coaches, no case managers, and the whole thing with the glue. We do need the glue, and we do need the puzzle pieces. And I would argue, if you've got glue and no pieces, you got a problem. But what we've got now is we've got pieces and no glue. So we need both. Integration is happening all over the country, thank goodness, but we need to fund it if we want more of it. And we've got many of you are probably here today working on these important issues, and so thank you for all you contribute to the PCPCC. If I haven't convinced you all, you need to become members. Please do, and please join us for our special interest group. There's my president, Paul Grundy. How many of you have heard of Paul Grundy? Oh, isn't he funny? And he makes it very easy for me to do my job because he is out there proselytizing. He started our organization. He works for IBM. We started in 2007. Mostly we're a convener. And we're an influencer, and we do that through collaboration. We're lots and lots of different kinds of providers and patient groups, and even pharmaceutical firms, large health systems. Many of them are really starting to get religion around this. How many of you saw this scene when my favorite television character of all, because she loves government, Leslie Knope, met Joe Biden? Okay, I just want you to know, when I met Joe Biden, I literally said to him, there's only one person who loves you more than Leslie Knope, and it's me. And he totally knew what I was talking about. And what he did not know is I had a broken arm, but I'd taken my sling off. And so he's a very energetic guy, like that's for real. And so he goes to shake my hand with both hands. I screamed, the picture's terrible. We've got a big meeting in November 12th. For 3 days, we're going to be celebrating the PCMH. We're going to be talking about the hard issues. I will just say, if you come next year, you will see that I have stolen your whole debate idea. Truly, it is brilliant. I learned so much. I had so much fun. My stomach really does hurt, and that's good because I haven't done sit-ups in a really long time. And greatest film ever made. I think has a lesson for us, which is when everyone's doing their part, everything is awesome, and you can pick out your favorite character and then become that as part of the PCMH team. So thank you for having me, and thank you for all you do.
So we were planning to have some time to have a conversation with Marci and to invite you to ask questions and engage Marci. But we're running a little late, and we certainly didn't want to interrupt any of that. So I am going to, I have one question for Marci, and we'll probably have time for one question from the audience before we move on to the breakouts. At the beginning of your remarks, Marci, you mentioned the fact that the public at large has no clue what patient-centered medical home is. So what would you say, how should we engage the public in being the patients who take leadership in their own healthcare team? And is that what patients want? Or is that another notion that we've come up with?
It's a terrific question. When you ask patients, do you know what a PCMH is and do you want one? They say, I don't know what it is, and it sounds like a terrible idea just based on the name. When you explain the features of what a patient-centered medical home is, that it's about care coordination, long-term relationships, it's about having a team of folks help with your healthcare needs, they're all in. So part of this really has to be tailored to your patients and your community and what has meaning to them. And then the other part of what you need to do is help me change the name, which none of you are members of the press, right? You know, it's hard. We've got folks who say, but it's in legislative language. We've got to keep using the name PCMH. The challenge is we've got acronym soup. PCMH and ACOs and EHRs, and so what is a term that kind of unites us all? You'll be seeing a fair amount of activity in the public space. I don't want to steal anybody's thunder because Andy is here and he could get me into super big trouble, and that is maybe on Monday they are starting to launch a public campaign in family medicine that could be around primary care and that could be named Health is Primary. It could happen, I'm just saying. It could be millions of dollars being invested. It's possible.
Wow. Any of you have a question or a comment for Marci? If not, I'll just keep going.
Well,
Do you want to summarize the question?
Yeah, so the question is, how do we take away some of the stigma around folks who need behavioral health services? One of them, of course, and it's one of the impetus, I think, for behavioral health integration into primary care is you make it all one and the same. I mean, we know it's behavioral health services, but it's delivered in a co-located, integrated fashion, and so folks don't sort of feel singled out. I think a fair amount of this is generational. It's also class. It's also ethnicity. I mean, there's so many layers. No one in my family or in working class Midwest America goes to see therapists. And I assure you, when we do, they are not called therapists. They are called counselors. And and we don't talk about it. And if you're on a psychotropic drug, oh, well, this is just another blood pressure medication. So it's a real problem. But you know, it's so funny for me when I went to school on the East Coast and like I have all these friends bragging about their therapist. I kept thinking, what is wrong with you? Why are you saying that publicly? So it took me kind of going, oh, it's okay? Well, I'll get a therapist too. Actually, I do have a therapist, and she's super famous. Do you guys know the book, The Dance of Intimacy? How many of you know that book? Totally my therapist. And the first 3 times I met with her, I kept going, Harriet, you are so famous. And she finally just said, okay, so Marci, are you my patient or my publicist? I'm like, I'll do both. And it is surprising, you know, she lives in Lawrence, Kansas. She really does. And I'd read her book many years before she was my therapist. But the point is, even people saying that out loud, I have a therapist and she's famous. Suddenly, somebody, not in this room, but you know, somebody somewhere goes, wow, I wonder what's wrong with her. I mean, she seems all right. She sees a therapist, huh? And then they start thinking differently. So some of this just has to be about what we say out loud. And I know this is your world, but in public health, we're still pissed that we've been underfunded. So we need to help you.
I actually have another one unless somebody else does. And maybe this is more of a comment. I know there's a triple aim, but I think that what is left out of that, and maybe square isn't what we really want to promote, but that there's the provider satisfaction.
Yeah. And lots of folks say that. I mean, they have called it the quadruple aim because in reality, if this model is so fantastic and providers hate it, it's too onerous, which I would argue we're coming perilously close to creating a circumstance with recognition that providers are going, you know what? I'm out. Really? 140 measures? That's about 100 too many. So when you let the bureaucrats in or the scientists in, you have to be careful. We go crazy, and suddenly this isn't about people anymore. And thank goodness, you know, I sat on the 2014 NCQA recognition standards where we added behavioral health. That was an important gap that the PCPCC in particular was focused on. But the clinician satisfaction isn't anywhere as high of a priority as part of the process. Neither is leadership, which have to be first and foremost in everything we do. Neither is culture change. So you keep adding stuff, but our problem is we never take shit off that list. And then we wonder why people are like, I'm out.
So I wish we could keep doing this all afternoon, but we can't. So thank you all, and let's thank Marci once again.